Welcome everybody to this week's episode of Weekly Dose with Dr. Uday. Thank you so much for joining us. Today we're going to be talking about resistant depression. We have Dr. Vineka with us today. I'm going to start with introductions and then we're going to get right into what we have today. So for those that don't know me, my name is Dr. Uday. I'm a board certified family medicine physician based in Martinsburg, West Virginia. I co-own a primary care practice, namely Apple Valley Family Medicine. I also provide aesthetic services to my patients and clients. And with both modalities, my goal is to have my patients not only feeling good, but looking good. So Dr. Vineka, I'm going to allow you to introduce yourself. Welcome. I'm so excited to have you. So you can go ahead.
Thank you for having me. It's a great pleasure. So I am Vineka Heeramun. I am the owner of Joyful Horizon Psychiatry. We focus on mood symptoms, so treatment-resistant depression that we'll be talking about today, anxiety, OCD. And I also work on an inpatient setting. Right now, I'm the director of the women's unit, soon to be transitioning fully to outpatient.
Yay, that's so awesome. Okay, so let's start with what is resistant depression?
So, interestingly, there's no official definition for it, but in general, when somebody suffers from major depressive disorder and has not responded adequately to treatment modalities that are evidence-based, so this will be considered therapy or one or more medications. That's one of the definitions. Usually, I would say if somebody has not responded to at least two medications in two different classes of medications that are indicated for depression, that would be kind of a better definition of treatment-resistant depression. But every insurance company goes by their definition of what they mean by treatment-resistant depression.
Gotcha. So the other one sometimes that we get questions about is what causes it. So what would you say from your perspective would cause this to happen?
So a couple of different possibilities there. So we have the first one would be the genetic predisposition. So if depression is running in the family, especially if both mom and dad have it and grandparents have it, there is a high likelihood that the patient would have it too. On top of that, there are some like epigenetic factors as well, whereas depending on people's experiences, there are changes in the structural component of the DNA that would contribute to somebody having depression. Then there's some comorbid factors as well. So, for example, medical conditions that can mimic depression, and it's important to rule that out. And then a lot of psychosocial factors. So, for example, what the patient is going through, homelessness, financial difficulties, difficulties with families. In the festival period, for example, Thanksgiving, Christmas time, even though those are festive situations, a lot of people struggle with that because they meet with, family that maybe they have a history of abuse and they have to meet that person, or just the family conflict in general. So lots of different psychosocial factors contributing to that as well.
Wow. Yeah, that's actually a really, really good point. Okay, so then what would you say symptoms are of resistant depression?
So the basis would be the symptoms for major depressive disorder. And on top of that, it would be the characteristic, as we discussed initially, about the failure to respond to the treatment-based modalities. But the symptoms per se would be not like feeling depressed. The DSM criteria defines it as low mood or low energy anhedonia for at least 2 weeks. But in general, for treatment-resistant depression, it's been going on for longer. So the symptoms we see would be the depressed mood, decreased interest in doing things that they would usually enjoy doing, low energy, difficulties with concentration, uh, difficulties with feeling hope for the future. So a lot of hopelessness, lots of feelings of guilt, that significantly affects appetite a lot of times and sleep. So both insomnia and decreased sleep, or emotional eating with overeating and weight gain, or suppressed appetite with loss of weight. And then in the most severe conditions, it would lead to negative thoughts. So, for example, I wouldn't mind if I didn't wake up. So, passive suicidal thoughts, or just really active suicidal thoughts with an intention and a plan to kill themselves.
So, all right. So let's talk about diagnosis, and just so for resistant depression, just let us know how to diagnose it.
Okay, so the diagnosis is mostly a clinical one. So um, we go by the symptoms that we talked about earlier. So try to go by the DSM-5 criteria, and then during our initial assessment, we get all the history from the patient. So not just the symptoms, but also get a biopsychosocial assessment. So we were talking about how the contributions of the social factors have an impact on depression as well. And then a medical history, because sometimes medical conditions can also mimic depression, list of medications. Some medications can also contribute to depression. So just in general, some examples would be like beta blockers, seizure medications, benzodiazepines. Lately, there was, with the Montelukast, there was an FDA warning release that it can cause changes in mood and cause depression, anxiety. So we get the history kind of to guide us as to what exactly is causing the depression. There's also substance abuse that we cannot rule out, because substances will contribute to depression, or the other way around, mania as well. And then we get a thorough assessment of what has been tried for the depression, because for us to define it as treatment-resistant depression, the patients must have tried medications at the adequate dose for the adequate period of time. So some patients would try antidepressants for just 2 weeks and say that it doesn't work. Well, that does not satisfy that criteria, because it has to be at the optimal dose and for at least 6 to 8 weeks. Failing that, or no response or inadequate response, then would put them in the category of treatment-resistant depression.
Gotcha. So now, as far as treatment, what do you have available as far as treatment for resistant depression?
Okay, so treatment of treatment-resistant depression. Again, we cannot underestimate the effects of lifestyle changes. So lack of sleep, poor nutrition, they increase cortisol level, and that causes inflammation, decreases neuroplasticity. So having a good, healthy diet helps. Exercise helps with releasing endorphins, dopamine. People feel good after that. Then, in terms of medications, we want to optimize the patient's medication. So let's say the patient started on an antidepressant and started feeling better, but not good enough. So we first increase the dose. And then let's say after increasing the dose, they still are struggling, then we can use augmenting agents. So lithium, atypical antipsychotics, bupropion is other antidepressant that we can add on to typical SSRIs, SNRIs. And then if those don't work, or just to continue with the treatment, we would also encourage patients to have therapy. And what therapy does is, especially for the depressed people, it helps them change their negative beliefs into positive ones. Then there's also the biological treatments like TMS and ECT. So TMS is transcranial magnetic stimulation. And what happens there is we use a magnetic coil to induce a current that will stimulate the neurons directly. So that helps. So what they found is in depressed patients, there's an area in the prefrontal cortex that is underactive. So the TMS through the magnetic field helps the neurons fire better. So they are more functional. They are able to make connections better. So increase in neuroplasticity. ECT is also an option, which uses electric current directly. However, it has its limitations. For example, it affects cognition and it needs general anesthesia. So a lot of patients can't afford to do that 3 times a week, for example, when they're starting and they can't go to work, they need a driver to take them back and forth. However, with TMS, they can still go to work, take their lunch break, drive themselves. There's no anesthesia involved. They just come for their treatment and go back with their daily activities as if nothing has happened. And then we cannot not discuss about special K, which is ketamine. So ketamine is very popular right now, and there are different forms of ketamine. So intravenous, intramuscular, intranasal, sublingual, and oral. And the one that is clinically approved right now, FDA approved, is the intranasal one. So it works by, again, neuroplasticity and modulation of the glutamate neurotransmitter. And not only does it help with treatment-resistant depression, but it acts really fast and helps with patients who are acutely suicidal as well. So it's just a matter of time before the other modalities, like the other forms, are approved as well, probably. And then in the future, we're looking at treatments like psilocybin or NMDA as well. MDMA as well.
Okay. Now, I'm going to switch gears and ask a few things about you. Why do you do what you do?
So for me, I've always enjoyed connecting with people, knowing more about their lives. I would always, in high school or before that, I would go to the library and get all these psychology books. And at some point, so I did my residency in internal medicine and psychiatry because there was so much stigma in psychiatry. So I thought, okay, as a primary care provider, I could sneak in, an antidepressant here and there, and that will be better accepted than going to a psychiatrist and getting antidepressants. And then because of the love of the connection with people, I'm practicing more psychiatry currently. And then the reason I opened the clinic is because on the inpatient level it's a quick stabilization for patients that are acutely suicidal. And I always wonder what's going on with the patient, how are they doing? And a lot of times there were readmits as well. So the treatment resistant clinic helps with finding a long-term solution. And that's been very gratifying to see patients just regain their lives back from depression. Instead of just being constantly readmitted to the hospital, they now have a life.
It's well needed service that you provide. Thank you so much for what you do. Other question. So with all the experience that you've had, all the life that you've lived, if you had an opportunity to meet your 20-year-old self, what would you tell them? What would you advise them?
So I had a careers guidance counselor at school, and I had no idea what to do. I just knew it had to be the medical field. And she kept telling me, and I think she was annoyed by me because I kept asking her the same question over and over, like, what should I do? What should I do? As if she would magically know what I was meant to do. And one day she just stopped me and she's like, my girl, you can do whatever you want to do. And I was like, this is the silliest answer ever. But now looking back, I'm like, she was so right. We can do whatever we want to do. It's just a matter of enjoying the journey along the way, and then finding out, because we like, especially nowadays, I think a lot of teenagers or young adults are really struggling with what they're going to do later. There's so it's a normal process, just to embrace it, and don't be scared of failures. Failures is actually going to lead to success. We
That's
just
it.
need to learn what the experience is giving us, and then just it's okay. If I didn't do this, I would do something else. If it didn't work out, I would find my own way in something else. So it works out. It will work out. So my counselor was right.
You found out years later, right? It's
Years
so
later.
amazing what experience does for you. Oh, this is beautiful. Thank you so much for bearing with us. We had some technical difficulties, but she handled it like a champ. And so the other thing, since we're wrapping up, is if anybody wants to connect with you, how can they reach you and all that?
Okay, I'm gonna quote Dr. Tolu on this one. If anybody has treatment-resistant depression, or they have family struggling with treatment-resistant depression, or they are primary care providers or any other doctors dealing with treatment-resistant depression, and they're in Utah, please give us a call. Uh, and our phone number is 801-618-4303. We're also on at our website is joyfulhorizon.com. Email is joy@joyfulhorizon.com. Instagram handle, you guessed it, Joyful Horizon. And same with the Facebook page. So lots of joy everywhere. That's our goal for all our patients.
That's so awesome. Thank you so much. And then on the flip side, if you're looking for a quality family medicine physician, look us up, Apple Valley Family Medicine. Our number is 304-350-1087. And our website is www.applevalleyfamilymed.com. We did it. So everybody, thank you so much for joining us. And
Thank you.
we'll see you on the flip side. Thank you so much, Dr. Vineka.
Thank you for having me. Thank you.
Bye.